Dear colleagues, I'm happy to present the update of the PROBASE screening trial. It's a German prostate cancer screening trial that has enrolled about 46,000 participants. We're testing age as the main risk factor to stratify and develop and evaluate a new risk classification. PROBASE has enrolled from 2014 for 5.5 years until 2019. It is designed for a follow-up until age 60 because we enrolled men at the age of 45 that were randomized to receive a PSA value at 45 or to get a deferred arm screening with the first PSA at age 50. If the PSA value was elevated above 3, we performed and recommended a biopsy based on an MRI. MRI, however, was a research tool and was not used as stratification tool because when the trial was designed, MRI was not a standard diagnostic tool. Then we have an intermediate risk group with a PSA from 1.5 to 2.99. Those men will be followed after 2 years and in 2 yearly intervals, and a large group of below 1.5 that is recommended a 5 yearly interval for repeat testing. After 10 years of accrual, we can report some interesting findings on the low risk group, the adherence to the screening program, about the DRE, about MRI in middle-aged men, the tumor detection rate by systematic and targeted biopsies, and we have invented a prevention clinic for men at familial risk. I would like to start with the new definition of a low-risk group. We have published these data after analyzing all men that had a PSA below 1.5, and as you can see here, as opposed to the EAU proposed low risk, we could enlarge this population by nearly 20% and rarely found tumors. So the new low-risk definition as proposed by PROBASE is below 1.5 at the age of 45, and we don't need regular testing in those men. This is the suggested algorithm, and 90% of all men at age 45 belong to this low-risk group, and further testing for at least 5 years can be avoided. We have investigated adherence to such a risk-adapted screening program. In the beginning, it was hard to get people enrolled, but now we have a very good adherence rate. We compare this to the OPT program in Sweden. They have a participation rate of about 35% at the moment, and we started with 12% that accepted our initial invitation. But like in mammography screening, when participants were enrolled and they were okay with the study, they stick to the suggested risk algorithm. Over more than 6 years we have data, and only 20-30% of men do not follow our recommendations. A bystander effect was that in the deferred risk group we had to offer something, and DRE was suggested and is suggested still now in Germany as a routine screening test. We have published these data that DRE in our study was not a very useful screening tool. After offering this to 23,000 men, half of them did not accept it at all, and of those that accepted, 6,500 were tested with close to 60 suspicious findings. Finally, only 3 cancers were found, and many biopsies have been performed without any suspicious finding. Very interesting is now the MRI in middle-aged men, and this is really a new finding. We have published also these data, but now we have an extended analysis. In the beginning, we have seen that local and reference reading for MRI is important, and local means we have 4 academic centers, and reference reading was with 2 radiologists that in Germany are the experts in prostate cancer MRI. And even in this highly educated group, we could see a remarkable difference between local and reference reading. So we have to keep this in mind, that quality of MRI technique as well as reading experience is very important. And we have investigated now, because our suggestion was to biopsy in a systematic and targeted fashion, that targeted biopsies were inferior to systematic biopsies in terms of cancer detection. We have analyzed more than 500 biopsies with a confirmed PSA value above 3, and they underwent a combined systematic and targeted biopsy after MRI. But it was a problem because the target was not as good as it is described in elderly men. You can see this here. We have nearly half of the men with PIRATES 3 findings, which is very unusual in a normal diagnostic population. And we still see cancers in local reading with PIRATES 1 and 2. So MRI is really hard to read. This is the message. And we have to work on a very elaborate future MRI biopsy schedule in order to really replicate what has been published with MRI in the elderly man. We suggest that perilesional biopsies may change the game because we have reanalyzed. This is just submitted and is not published yet. And we saw that the systematic biopsies that were superior to find cancers were directly in the vicinity of the MRI lesions. So a penumbra biopsy technique probably may have solved the problem. This is then not in contrast to the Göteborg data that preferred targeted over systematic biopsies in a screening setting. Last, I would like to mention that men with family history are overrepresented in our study, and they are posing a problem because they are contaminating. They do not behave in the suggested risk-adapted regimen because they are really anxious. And we have developed a project that will be now expanded in Germany, which is called ProFam Risk. This is a risk-based personalized prevention clinic. And we offer those men a panel analysis of the known prostate-relevant genes in conjunction with an MRI. And then we have certain recommendations. It's kind of a registry. We're testing low, intermediate, and high risk groups. And depending on mutation status, we recommend yearly PSA controls up to biopsies if we have found a pathological variant. So far, we have enrolled about 100 men in this trial, which is running in parallel to PROBASE and will be, as I said, expanded over Germany in the next years. So in summary, risk-adapted organized screening like we tested in PROBASE makes sense because obviously the baseline PSA concept that has been published by Andrew Vickers more than 10 years ago works and is accepted by participants. This strategy reduces harm because those at low risk do not need further investigations. And we probably are going to find every relevant cancer with this regimen within the 10% men at intermediate or high risk at this age. If we then add personalized treatment like active surveillance, and this is chosen by more than 30% of our participants, we further diminish harm by this strategy. We have detected some challenges, so start and end of screening is still unclear, and the quality of the investigations, including MRI and PSMA PET in cases of relapse, is still important and needs to be investigated in future research. Finally, I would like to thank all participants of this study and my whole PROBASE team from Hannover, Heidelberg, and München. You can see the main investigators there. The study is coordinated at the German Cancer Research Center in Heidelberg, and I'm co-affiliated in both of these locations. Thanks to all of them, and we are going to report more interesting findings over the next year. Thanks for your attention.